Hello, this is Kim Jong-il. Today we'll cover the second part of our lectures on lingual arch indications. We can use lingual arch for space maintenance. This is a case of mixed dentition, in which the second deciduous tooth has already been removed and there is a space in the mandibular anterior region. Is this space normal? During mixed dentition, the space of the maxillary anterior region is normal, but the space of the mandibular anterior region is not. In this case, the space must be closed with a slightly lingual movement of the mandibular incisor. The lingual arch was used here to close the space while maintaining space for the second deciduous molar. I gave some space between the anterior part of the lingual arch and lingual side of mandibular anterior teeth, and closed the space by using 5/16 6 Oza light elastics. As such, the lingual arch can be used to maintain the second deciduous molar space and close the space closure of the mandibular anterior. Secondly, many try to move the mandibular anterior as posteriorly as possible by reinforcing the anchorage through mandibular lingual arch. I don't use lingual arch for this purpose. Since the mandible is a compact bone, we can close the space by strategically filling space without using the lingual arch. The first cause of scissor bite is the over-eruption and the buccal eruption of the maxillary second molar. We must first intrude the maxillary molar and move it palatally. We must intrude the mandibular molar and move it into the dental arch. Thirdly, the lingual arch can be used to buccally enlarge the constricted lower arch in cases of scissor bite. There are several devices that can be used to do this. Many use crossbite elastics, but this is not recommended. Instead, it would be better to use the lingual arch, fixed appliances, mini screws, or Schwartz appliances with an expansion screw in the mandibular anterior region. In this case, activation is required in the lingual arch. We must adjust the U-loop to buccally upright and expand the lingually inclined tooth at the mandible. This patient displays a posterior scissor bite on the left area. 4, 5, 6, 7 on the left side of the maxilla are extruded, and 5, 6, 7 of the mandible are lingually inclined. In order to intrude 4, 5, 6, and 7, one mini screw was implanted on the buccal side, and 2 mini screws were implanted on the palatal side, and a power chain was used to pass the auxiliary wire on the occlusal surface. In the mandible, Schwartz with PBB was used to eliminate occlusal force and enlarge the mandible arch. Due to the expansion, space was created in the mandibular anterior region. Mandibular extensions with Schwartz have limitations, but further extensions can be made by using a lingual arch. When the expansion is satisfactory, we can finish the process by attaching brackets and leveling remaining teeth. This patient's tooth 15 is rotated. Rotation control takes a lot of time, so it would have been better if it had been controlled earlier. After intruding the maxillary left molars, I applied TPA to the maxilla and rotated the tooth 15. A previously hidden cavity was found and treated during the rotation. The treatment completed with the placement of MIOs in the mandible and maxilla. The treatment took 16 months, but it took this longer only because the rotation control of tooth 15 started late. As in this case, the lingual arch can be used to buccally upright a constricted mandibular tooth. An impacted tooth has an abnormally root shape and is very resistant to movement. If we perform traction on an impacted maxillary central incisor like this, the adjacent teeth will be tipped and the anterior region will be intruded, resulting in canting in the occlusal plane. If it's slightly impacted, the impacted maxillary central incisor can be pulled with the open coil spring. But if it is severely impacted, it is recommended to install the lingual arch using tooth 6 and pull the impacted maxillary central incisor. The same goes for impacted maxillary canines. If the canine erupts on only one side, it indicates that the root of the impacted canine would have developed quite a bit and would have an abnormal shape while growing. In this case, if we use the open coil springs to pull the impacted canine, canting is highly likely to occur. Therefore, in the first step, it is advisable to solder the lingual arch with an auxiliary wire to pull the impacted canine back where it was. When it is exposed a little bit from the oral cavity, we pull it on a fixed appliance and an open coil spring. There are many cases in which the mandibular canine or first premolar is impacted. This patient has impacted mandibular tooth 33. Of course, there is not enough space, so we must gain some. If we change the direction of the impacted canine through the lingual arch first, then use an open coil spring to pull the canine, it will be easier to obtain space. The same goes for this patient. Tooth 33 is impacted because of the supernumerary tooth. If we pull an impacted mandibular canine directly from the OCS, the adjacent teeth will be tipped and the treatment will take longer. A more efficient approach would be to solder auxiliary wire to the lingual arch to pull the impacted canine first, and then provide space for the canine by using strategic bonding and open coil springs. We can use mini screws to induce backward traction of the impacted mandibular second and first molars. In other cases, we can use the lingual arch. I decide whether a buccal tube can be attached to the impacted mandibular molar, like example A, a lingual button on the buccal or occlusal surface like example B, or nothing like example C. In cases like C, where no device can be attached, the mandibular third molar must be extracted and a mini screw must be implanted. When pulled with a power chain, treatment becomes easier because the direction of the traction head to where the impacted mandibular second molar distally extrudes. However, if there is no bony area after extracting the third molar, we might not be able to implant the mini screw. To pull the impacted mandibular second molar to the distal, we can use a power chain to pull it from the distal hook. The mesially inclined mandibular second molar moves distally, and the mandibular first molar moves mesially by the principle of reaction. The mandibular first molar is most likely to incline mesially because it requires a lot of force to pull the second molar. Therefore, it is recommended to distribute the reaction force to the left and right first molars by using a lingual arch. In this case, the mandibular first molar is impacted. The mandibular second premolar is missing. How should we treat this? We should apply a lingual arch on the second primary molars and extend the auxiliary wire to the rear. Afterwards, we attach the lingual button to the impacted mandibular first molar through Windows opening and pull it back. If it erupts enough, we can level the first molar by attaching a buccal tube to the mandibular first molar and welding the bracket to the second premolar. When using a face mask maxillary protraction appliance on a growing class 3 malocclusion patient, we can use bonded RME with hook, labiolingual arch with hook, fixed appliance and Kobayashi hook, which are intraoral devices, on the first premolar. Among them, the bonded RME with hook is the most effective. The maxillary A point moves forward the most because the maxillary bone is pulled forward, spreading laterally. The problem is that because bonded RME with a hook covers the occlusal surface, it is likely to have caries in the maxillary first molar. Therefore, for cases where the maxillary first molar is already erupted, I recommend the use of a labial lingual arch with hook over bonded RME. Band to the maxillary first molars and insert the wire in the labial and lingual side. There is an auxiliary hook between C and D, which allows us to pull the entire maxilla forward and move the A point forward within at least 6 months, which ultimately improves the dental relationships. We can use the lingual arch for such purposes. It is easy to think that a narrow maxilla is caused by posterior crossbite, but a wide mandible may also be a possible cause. The eye use an arch coordination sheet to find the cause of the posterior crossbite. The normal maxillary intermolar width distance between the first molar's mesiobuccal cusps is 50.6 millimeters. This patient has a 49 millimeters, relatively small, but this is still in the normal range. The normal intermolar width of the mandible is 43.9 millimeters, but the patient has 50.1 millimeters. This patient's posterior crossbite is due to the wide mandible. We can observe that tooth 37 is in a normal position, and only tooth 36 is buccally protruding from the dental arch. In this case, we must not only expand the maxilla, but also move the buccally protruding tooth, number 36, lingually in order to treat the posterior crossbite. To move tooth 36 lingually, we can attach a hook or loop to the lingual arch and connect the power chain. At this time, 3 to 5 millimeters of space is required between the lingual arch and the lingual side of the first molar to allow the first molar to move to the lingual side. This patient was installed a lingual arch and was used with power chains between a hook and a bracket tooth number 36 in February. Blue resin was placed on the occlusal place of the first molar to guide the power chains. Here are the intraoral photos from February, March, and April. In only 2 months, the mandibular first molar has relocated inside the dental arch. The mandibular first molar has moved 3 millimeters lingually, and the intermolar width of the mandible changed from 50.1 to 47 millimeters. In such cases of crossbite in which one tooth, especially the mandibular first molar, is buccally positioned, we can use the lingual arch. In order to move the mandibular first molar lingually, it is possible to engage by constricting the mandibular lingual arch, but this is not effective. Therefore, if mandibular tooth 7 is normally located in the dental arch, I use a lingual arch and power chains with a U-loop and hook to relocate the buccally located first molar into the dental arch. We can observe transposition and impaction on tooth 23 for this patient. Tooth 23 is located between tooth 21 and tooth 22. It is technically possible to finish the treatment in a transpositioned state, but this is not aesthetic. This is the case of no crowding in the mandible and non-extraction treatment. The maxillary canine must move posteriorly back to where it was, but the maxillary lateral incisor is an obstacle. The lateral incisor should be moved palatally. TPA or lingual arch can be used to move the lateral incisor toward the palate. To avoid contact with the mandibular teeth during this movement, the occlusal force must be eliminated. A PBBA which covering the anterior region was attached to the posterior bite block, and a hook was soldered to the TPA in order to pull tooth 22 palatally and 23 buccally. We can see that this resulted in the crossbite of tooth 22, which was originally in its normal place. Tooth 23 is exposed at the 22 distal. The treatment was completed by moving tooth 23 to its original location. We can observe the root of tooth 22 is located on the palate side. Please refer to the transposition part for further details on the treatment process. How would the patient's dental root be when the treatment is completed? The orthodontic treatment was completed without any major problems on roots of tooth 22 and 23. The ninth possible use of the lingual arch is as a habit control appliance for the maxilla. If you have a habit of sticking out your tongue or sucking your fingers, you can correct the habit by adding a tongue crib to the lingual arch as shown in the picture. This is a 13-year-old female patient. Her mandible is protruded, and the anterior and posterior teeth display crossbite. The treatment is completed. How should we maintain this after the treatment? It is recommended to use TPA and lingual arcs in the maxilla to prevent recurrence of the posterior crossbite. If we use a removable device as a retainer, there is a high possibility that the enlarged upper jaw will become narrower again if the patients do not use the device as often as they should. In this case, posterior crossbite will reoccur. Therefore, the lingual arch can also be used as a retainer after treatment of posterior crossbite, the 10th possible use of lingual arch. To summarize the indications for lingual arch: 1. Space maintenance. 2. Anchorage reinforcement. 3. Buccal expansion in case of constricted lower arch scissor bite. 4. Traction of impacted anterior and canine teeth. 5. Traction of the impacted mandibular first and second molars. 6. Use of maxillary protraction appliances such as face masks. 7. To lingually move the buccally positioned mandibular first molar in the case of posterior crossbite in which only the mandible is enlarged. 8. Traction of transpositioned teeth. 9. Habit control. Retention device after treatment of the posterior occlusion. Thank you for watching.